Now, this is discomfort is chest discomfort mostly, or maybe discomfort with the idea that someone was pushing on their chest. 6 of them, 2%, had fractures. Now, this is an interesting bunch. 3 of them had rib fractures, 1 had a clavicle fracture, and 1 had a hip fracture. How did that happen? Well, actually, they did know. The person, they said, you need to get them flat on their back. And so they yarded them right off the bed, and the poor little old lady went flat on her, and broke her hip. There were, now, this is kind of an outlier. I'm not sure we want to say that this is a reason not to do CPR. No visceral injuries. In other words, no spleens were hurt. No spleens were damaged in this experiment or in this movie. There was some tracheal bleeding in one case, but they didn't really know where it came from and whether it had anything to do with the CPR itself. No one knew, because there was no fractures associated, there was nothing. So, in other words, there's very low risk of serious injury from doing CPR, even if the person isn't in cardiac arrest. And the upside is that so many more people we think are going to benefit from good dispatcher-assisted layperson at the scene CPR. Questions?
In the Arizona study you mentioned, was it looked at downtime and presenting rhythms as part of that compression-only standard?
Downtime. Well, I'm not sure. I think these were considered to be witnessed arrest, I think. Yeah.
And presenting rhythm?
I don't know that. I'm not sure that they called that one out. It would make sense that we would sort of interpret the presenting rhythm probably as VFib or pulsus vitac. Although, and that's when you look at the Seattle data, Seattle is very, very clear on that. They report all comers and they report all outcomes, but they also like to report, especially when they're doing their yearly budget thing, they like to report the VFib arrest particularly, which is for last year, 47% survivor. Now, their survivors are also not as high, probably as highly Rankin scored, neurologic outcome. They hadn't been up to now as careful, but they've got something that's worthwhile working for. Any other questions?
What about rural areas where response times will be longer?
Yeah.
Are they going to consider ventilations out there, or how's that going to affect?
I think that's a real good question, and I think that would be up to your medical director. But it would make perfectly good sense. There is the ROC, at least as I understand it looks like the Canadian, at least one contingent of Canadians are going to do a study on compression-only CPR for the first 5 minutes for ALS and BLS responders. So I think the idea is they will go to ventilations after it. Now, when we do that kind of a study, or with ALS or BLS, you're also going to have just a mask on the patient and blow-by mask and probably an oral airway, and then with blow-by oxygen. So the theory is that compressions alone will do some oxygen mixing at that point. But it's a good question. I don't know how long when, the thing with compression-only CPR for a rural area is that, grandma's not going to be able to keep pushing on this chest for 20 minutes waiting for BLS to show up anyway. Yeah. There are some advantages and disadvantages to living in the country. Other questions? Okay, thanks. Break time.
All right, folks. Yeah, so we will have a break. Let's make it 10 minutes. We'll meet back here at 10:45. And if I can just make one last point and follow up to what Dr. Whitmore had to say, I'd say that you guys shoulder the lion's share of responsibility in out-of-hospital cardiac arrest, right? You've heard so far that to a large extent the outcome is dictated by what happens in the field. I think what was just presented to me anyway suggests that that responsibility should not fall entirely to you, nor should it fall entirely to us in the hospital, but is actually part of the community buying into improving cardiac arrest survival rates. And so that means gaining some traction in the community for bystander CPR. So at some point you hit a ceiling effect with survival to hospital discharge and improving neurologic outcomes. And we're probably starting to bump up against that ceiling. And so, for example, Seattle has a bystander CPR rate of 70%. 70%. That's really, pretty amazing. And us at a 30 to 40% range, I think, have a significant room to improve. So it's a matter of recruiting the community into this effort as well, getting their buy-in, their training, and their help in improving survival rates further. All right, we'll be back 10:45. Thanks.
Morning to talk to you about the two concurrent hypertonic saline trials that we all participated in and worked so hard to complete. And I want to show you the results of those and talk about the two studies a little bit as well. So just a little bit of background. Why would we even think about using hypertonic saline? What's the benefit of hypertonic saline? Well, one of the major potential benefits is that you can essentially equivalently resuscitate a patient with 250 cc's of hypertonic saline versus 2 liters of normal saline. There's essentially the same amount of salt in a one little 250 cc bag of hypertonic saline versus 2 liters. So you can see that, from an EMS standpoint, a rural standpoint, and primarily really a military standpoint. In the field, in military settings, the fluid is carried by the medics. So if you can carry a 250 cc bag and get equivalent resuscitation with 2 liters, I think that's very much of a superior situation. Also, with those smaller volumes, when you give the fluid, you get a more rapid restoration of intravascular volume because hypertonic saline will actually bring fluid from the third space into the intravascular space. Those are arguments from the shock standpoint. If you think about it from the traumatic brain injury standpoint, there's really some different advantages. Number one, hypertonic saline is effective at rapidly raising the systolic blood pressure, which improves cerebral perfusion pressure. At the same time, hypertonic saline creates a gradient across the blood-brain barrier that draws fluid out of the brain and actually shrinks the brain. So you're increasing perfusion of the brain, but also decreasing the intracranial pressure. So that's a real major advantage. One of the other major products that's used for head injuries is mannitol. Mannitol is a diuretic, so if you have a patient in shock and you give them mannitol, you can actually make their hypotension worse. So you can see some serious advantages. Furthermore, hypertonic saline in basic science studies has been shown to decrease inflammatory response, and there's a theoretical possibility that hypertonic saline will reduce the incidence of things like ARDS and multiple organ failure. There's really been several trials looking at hypertonic saline. None of them have been definitive. The results are relatively mixed. They've been limited by sample size. They're usually single-center trials. The type of hypertonic saline has not been fixed. Different concentrations of hypertonic saline, all the way from 3% to 23% hypertonic saline have been used, and they've been used with and without dextran. So it's important really to more objectively choose those solutions. The other problem is in all of the real large prospective randomized trials where trauma patients are being looked at very carefully, the survival rates are always better than predicted. And that's actually what we saw in this study as well. So when you see better than predicted survival rates, that's great. But if nobody's dying, you can't show a mortality benefit. And that's one of the problems. So the hypothesis of the two studies, the two concurrent hypertonic saline studies, was that out-of-hospital administration of hypertonic saline with or without dextran would reduce mortality for injured patients both in hemorrhagic shock and for patients with severe traumatic brain injury. The ROC study you've probably heard about already a lot over the course of the last several years, but it's 11 sites across North America, 114 EMS agencies, ground and air. So this is a huge study all around the United States and Canada. The studies occurred from 2006 through 2009. They were prospective and randomized. They were placebo-controlled, the placebo being 250 cc's of normal saline, and they were all blinded. Nobody knew what solutions the patients were getting. Patients were randomized either to 250 cc's of 7.5% hypertonic saline, 250 cc's of 7.5% hypertonic saline with dextran 70, or 250 cc's of normal saline. The initial fluids were all given by pre-hospital providers, and the further fluid was not guided. The additional fluid was based on the protocols of the EMS agencies, and it actually turns out that all the groups got about the same amount of fluid. These are the locations of the ROC. You can see they're located East Coast, West Coast, Southwest, and Midwest, as well as a couple of sites in Canada. In terms of the inclusion criteria, these were blunt or penetrating trauma. The age had to be greater than or equal to 15 years, and if the age was unknown, then the patients had to be greater than 50 kilograms of weight. In the shock cohort, we really wanted to be sure that the patients were truly in shock, so the inclusion criteria was a systolic blood pressure less than or equal to 70, or a systolic blood pressure 71 to 90 with tachycardia, or heart rate greater than or equal to 108. In the TBI cohort, it was very simple. GCS less than 8 was the inclusion criteria. The typical exclusion criteria were invoked: pregnancy, ongoing CPR, drowning, hanging, burns, severe hypothermia, penetrating injuries to the head were excluded, dispatch to intervention greater than 4 hours. We didn't want patients who were prolonged in the field. And anybody who got more than 2 liters of fluid prior to being randomized in the study were also excluded, and of course prisoners. The primary outcomes for shock was 28-day survival. Very simple. Was a patient alive or dead at 28 days? And for TBI, 6-month neurologic outcome based on the Glasgow outcome score, the extended score, was the primary outcome. So neurologic status at 6 months. How was the patient doing from neurologic status at 6 months? Secondary outcomes were organ failure, ARDS, infections, and then vent-free days and ICU and hospital days. We also had pre-planned subgroups. There's populations differ in many ways. So ahead of actually doing the study, subgroups were planned. These included blunt versus penetrating trauma, severely injured patients, patients with transfusion requirements, and patients who required hemorrhage control. Overall, this was a huge effort across North America. 2,221 patients were randomized in the study. It turns out that since in North America primarily most trauma is blunt trauma, TBI was much more commonly enrolled than shock. It turns out that 2,221 patients were enrolled. 852 of the shock were evaluable, and 1,282 of the TBI were evaluable. What this meant was that at 6 months, we had the primary outcome data on this number of patients. This is well over 95% of the patients in both cohorts. So if you guys enrolled a patient, they were almost certainly followed up, which I think is a really impressive effort. And people all around North America went to extreme efforts to find these people. They sent them multiple letters, they called them. Some people drove into rural areas and tracked people down, and the efforts were just incredible. Both trials were stopped early by the Data Safety Monitoring Board due to futility. So based on planned interim analyses, there was not enough differences between any of the groups to permit the study to go further. So in both cases, there was no difference in the 3 resuscitation groups, and the studies were stopped early. So here are the results. I'll start with the shock results. This is the 28-day survival. Absolutely no difference in 28-day survival. You can see that the numbers are actually quite similar, about 74, 75%. This is a very good survival rate for these severely injured patients, which again is part of the problem in these studies. If not enough people die, you can't show a difference in mortality. Again, I think this is great, though. I mean, we were saving our patients, and that's what counts. Now, interestingly, if you look at these graphs for 28-day survival, you start to see a separation in early mortality for the 2 hypertonic saline groups, and I'll show you that a little bit better. Now, looking at the shock results by transfusion, very interesting results. If you look at this, for patients who got 0 units of packed red blood cells, mortality was actually significantly lower in the normal saline group. Mortality lower for patients who got 0 units of packed red blood cells. Now, there's 2 reasons to get 0 units of packed red blood cells. Who can tell me the 2 reasons that these patients would get no packed red blood cells? Actually, that wasn't one of the major reasons in this case, but that's a good point. That would be one reason, but not one of the 2 major reasons in this study. Who can tell me the 2 major reasons you think? What's that? You guys don't carry packed red blood cells. If the patient dies in the field, they're not going to get any packed red blood cells. So early mortality would be a reason why patients don't get blood, because you guys don't carry blood. The second reason is they just didn't need it. So the patient came in, they really weren't that hurt, and they didn't need blood. Now, remember I showed you the earlier graph, there was a higher earlier mortality. The main reason we think why this difference occurs is because patients who died early were more likely to be in the hypertonic saline groups. And that's why they didn't get blood, and that's why the mortality is higher in this part of the evaluation. Now, if you look at patients who got 1 to 9 units of packed red blood cells or greater than 10 units of packed red blood cells, you see that there's absolutely no difference in mortality amongst the 3 groups. And if you look at this group that got greater than 10 units of packed red blood cells, the mortality is extremely low. Typically, in studies of patients who get massive transfusions, mortality rates are somewhere between 30 and 60%. And in this study, mortality rates were extremely low, between 5.5% and 6.8%. So again, attesting to the very good survival that we saw in this study. Now, this is a better look at that early mortality. This is, instead of in days, this is in hours. And what you see is a trend toward very early mortality in the groups that got hypertonic saline. So the dotted line here and the dashed line are the hypertonic saline groups. And what you see is that there's much earlier mortality in these 2 groups, particularly in the hypertonic saline group that did not get Dextran. So for whatever reason, we saw a little bit higher mortality in these groups. And I actually think that the reason why that was is because the patients didn't only get the hypertonic saline, but they also got another liter of crystalloid on top of it. All the groups, in all 3 groups, everybody got about 1,200 cc's of fluid pre-hospital. And I think that the extra liter on top of the hypertonic saline was actually fluid overload in these patients and resulting in early mortality, although these differences did not reach statistical significance. Now, in terms of secondary outcomes, ARDS, multiple organ failure, ICU length of stay, all these things, no differences between the groups. They're all the same. So that earlier mortality was made up for better long-term outcomes in the hypertonic saline groups, and overall there was no difference. Now, in terms of the TBI groups, TBI results, all 3 groups, the 3 randomization groups, were very evenly matched. There was no differences in ICP monitoring or interventions between the groups. There were persistently higher sodium levels in the groups that got hypertonic saline. This makes sense. They got hypertonic saline, so their sodium levels were higher. There were no adverse events or safety issues in the study. These are the results, and what this is showing you is that if you break down the groups by Glasgow outcome scale, the extended Glasgow outcome scale, there's no difference in any of the groups with respect to terms of their Glasgow outcome score. So regardless of what regardless of what they were randomized to and what their Glasgow outcome score, there was no difference in outcome. So absolutely no difference in outcome between the 3 groups. Also, looking at other outcomes, in addition to 28-day survival, ARDS-free survival, worst MOD score, ventilator-free days, etc., no differences statistically. Interestingly, though, you'll see there was a strong trend toward less infections in the normal saline group. Remember, hypertonic saline has been shown to be anti-inflammatory. Maybe it's actually a little bit immunosuppressive as well, although this group did not quite reach statistical significance. The limitations of the study is that in-hospital care was not standardized. We had guidelines on how to manage patients, but there was a significant degree of variability. You can imagine if you're looking at 11 centers across the United States and Canada, there was a degree of variability in how the patients were managed, and that's a limitation. Additional fluids were given. So patients, again, got an average of 1.2 liters regardless of the group they were randomized to, and they got about 11 liters in the first 24 hours in all 3 groups. No difference in the amount of volume given, And I think that may dilute the effects of the hypertonic saline to a degree. And there was a little bit of lost follow-up, although it was actually quite good. So in summary, in both studies, TBI and shock, we saw higher than predictor survival in all the groups, again, making it more difficult to show differences. In the shock group, there was no difference in overall 28-day survival between the treatment arms, but there was a higher mortality seen in the patients who didn't get any packed red blood cells who got hypertonic saline. Again, we think this is the early mortality. And there was no difference in 6-month neurologic outcomes in the TBI group. So in conclusion, this is by far and away the largest out-of-hospital clinical trial ever performed on hypertonic saline resuscitation. This is a credit to you guys because you guys did the study. We just followed up on the patients. You actually randomized the patients, and you guys are responsible for this study being a success. There was no improvement in the 28-day survival among the shock patients and no improvement in 6-month neurologic outcomes. So this was essentially, both of these studies were essentially negative trials. Now, is that good or bad? Well, I would argue it's good because what it's doing is it's adding to our knowledge about what these fluids do, and I think that's very important. It's very important to publish negative as well as positive trials. This contributes to the scientific knowledge. I, however, would argue that this does not definitively rule out potential benefits of hypertonic saline for these purposes. What I think really needs to be done is that we give the fluid the single 250 cc bolus of the hypertonic saline fluid, both for shock and for TBI, and then not give any additional fluids. And that's really what the military wants. The military wants to see what would happen if their medics just give a single bolus of 250 cc fluids and see what the outcomes are. So I do think this was an excellent study. It was very well performed. You guys did a fantastic job, and the follow-up was thanks to some of the people in the room here as well, was outstanding. So I congratulate you all on this effort. I'll take any questions.
Were you surprised by the findings of the survey?
I got to tell you, I'm going to be frankly honest with you. I was absolutely not surprised at all because I vehemently argued that we should not do the study this way. I was worried from the beginning that allowing additional fluid to be given was going to dilute out the results, and I more or less predicted this. I really think that if you want to study hypertonic saline, you've got to study it by itself. That's how that's what the fluid is designed to do. It's the equivalent, giving one 250 cc bolus is equivalent to giving 2 liters of normal saline. So why give more normal saline on top of that hypertonic? I'm not surprised. I was a little surprised by the early mortality thing. I wouldn't have predicted that. Another question in the back?
So since this was a negative result in the study, is the military still going to carry the 250 cc's of hypertonic?
So that's a great question. For those of you that don't know me, I just got back in September. I was the Joint Theater Trauma System Director for operations in Iraq and Afghanistan. The answer to the question is that the recommended fluid for pre-hospital resuscitation by the military is a fluid called Hextend. Hextend is a colloid, much like Hespan. It's a starch, but it's in a balanced salt solution. It's been shown to reduce blood loss in patients undergoing major surgery. So that's the recommended fluid. Despite the fact that that's the recommended fluid, 60% of military casualties still get normal saline. Hypertonic saline has been considered by the military, but is not in wide use. And the reason was the finding of the Hextend that it actually may reduce blood loss, and that's a very important aspect of it. The initial dose of Hextend is 500 cc's, so it's actually twice the volume of the 250 hypertonic saline. But the military was really hoping to get a good study here and see what the effect of a single bolus of 250 cc's of hypertonic saline was. And if that showed a benefit, they would have switched their fluid to 250 cc's of hypertonic saline. Okay, thank you. Oh, question?
Is this something that's expected to be studied further in the future?
That's a great question. It is not one of the proposed studies for the ROC at this point in time. There's several studies that are being proposed. Estrogen is one of them, pre-hospital estrogen for shock and TBI. Hypotensive resuscitation is being proposed, and a study looking at lactates obtained in the field are being proposed. So hypertonic saline is not one of the proposed studies for the future in the ROC. There are others out there, though, that are considering it, but there's no active study of it right now, no proposal that I'm aware of to study it right now. All right, thank you.
Sorry. Trying to keep the order straight here.
Okay. This one. EMS provider.
The cognitive reasoning, yeah, that's right. The, actually, the cognitive reasoning one just, yep. Okay, so we have just a little bit less than an hour left to cover 3 more talks about trauma. I'm going to try to make sure we finish on time here. So I'm going to be presenting this next talk in concert with Doug Boyce here about field provider cognitive reasoning and trauma triage. And something I probably should have mentioned during the opening remarks is that I think all the physicians in the room here, as well as the majority of those that are actually involved in EMS research in this region, have some background in field care, whether it's being a previous field provider, EMS medical director, combat experience in the military or otherwise. So I think there is a special link that all of us feel about how you do your job and what happens in the field. And our version of the Ivory House, I'd say, is kind of a modified Ivory House where periodically involves vomit, blood, urine, a variety of other things. We're not sure what they are, people yelling at us, that sort of thing. So we're not so far from it. It gives me sort of a special basis to talk about some of these things, in particular this next talk that essentially is a topic about thinking about how you think, or in general terms, thinking about thinking. And it seems sort of philosophical or abstract, but I think as we go through this, it'll become a lot more clear. So field trauma triage is something that all of you know about. It's integrated into training programs. This is something that all of you use on often a day-to-day basis. Very critical component of trauma systems. So this concept of concentrating resources in certain high-resource hospitals, i.e. trauma centers, and trying to select out the most seriously injured patients, that is those that are most likely to benefit from trauma center care as the process of triage. Wouldn't be a wise use of resources if we sent every injured patient through trauma centers. It would overwhelm that supply of critical resources. So there's a very important need for triage in the field. The original scheme was developed over 30 years ago by a group within the American College of Surgeons, been updated every 5 to 10 years, most recently in 2006. This component of triage and trauma systems is a model for regionalized care of patients with many other conditions. You see it now being implemented for STEMI, cardiac arrest, stroke care, and on the horizon are things like sepsis and other conditions. However, the reasons for selecting certain hospitals and the field-based actual decision-making for where people go and transport patterns is quite poorly understood, as is the process for actually conducting triage in the field. So that was the basis for this project, was to be able to evaluate how field-based triage decisions are made, be able to better describe EMS provider cognitive reasoning and reasons for selecting specific hospitals. We use a population-based retrospective cohort, all injured patients. So this was not just trauma entries, not just the most seriously injured. This was all comers, entries and non-entries. Looked at the 4 county regions, of course, Clark County included, over a 3-year period. 10 agencies, and 16 hospitals. So, as I'll show you subsequently, there were some numbers that we generated that we really could not explain, and so we added what's called a qualitative component to this study. We spent 60 hours in the field during 10 ride-alongs that were evenly divided across all 4 counties, ambulance and fire agencies, structured interviews with 35 field providers, as well as field observations. And interestingly enough, during last year's research summit, we held a roundtable focus group with EMS agency leadership that included fire chiefs, EMS administrators, EMS medical directors, training officers, and other personnel to glean some more information about this topic. These notes were transcribed and reviewed with key ideas, phrases, themes, looked at how they interacted and influenced each other with the general goal of developing a conceptual framework for field triage, essentially how it's really done in the field that we'll show you this morning. So in total, just over 64,000 patients, 17% of these, at least of those transported, were trauma entries. Over 90% of those trauma entries were transported to level 1 and 2 centers. And this next number is sort of interesting as well. Almost 30% of non-entries were also transported to major trauma centers. This is the piece of information that was sort of curious when we first looked at it. So the most commonly cited triage criteria was EMS provider judgment in more than a third of cases. And it also accounted for almost a quarter of trauma entries where there was only one triage criterion listed. So we saw this, said, what is the basis for this? How did, what's sort of the background here? So if we looked at overall reasons for selecting certain destinations, remember these are trauma entries and non-entries. Patient and family request was cited over half the time. Hospital proximity, 17%. Specialty hospital, sort of a surrogate for trauma centers. Remember, this is all of your data. This is not us generating this. This is what is marked in the EMS record. The rest of these explanations, a much smaller percent of the time. So I'm going to show you the qualitative results here. I think this is probably the most interesting part of it. There were basically 4 themes that came out of interviews, field observations, this roundtable for how triage is actually done. And the first one was gut feeling. So this was far and away the most commonly cited primary reason for identifying a trauma patient or a trauma system entry, heavily influenced by dispatch information, mechanism, early visual cues from the scene, including the appearance of the patient, most commonly done without yet laying hands on the patient. It was done as a form of rapid cognitive processing, put together a lot of information, come up with a very quick final conclusion. It was also heavily influenced by provider experience. Notably, this is opposite to the way the algorithm is laid out for triage. Second theme is EMS provider experience. So also a significant factor in interpreting information. Most of the people we spoke with felt that the most experienced provider guided that field-based decision-making process, and multiple people cited the triage algorithm as for quote-unquote newbies. So this was something that was learned in paramedic school, practiced maybe for the first year or so. Once you had enough experience under your belt, it was not followed. It was based more on gut feeling and intuition rather than a structured algorithm. Theme 3, patient and provider preferences. So for non-trauma entries, patient and family preference was far and away the most important, and we demonstrated that in the numbers that I put up here earlier. If there was no preference, proximity played a big role, diversion was a smaller role, and this last point I thought was interesting, that you as field providers take into account a lot of different aspects in picking a hospital. And this may be more of an issue where there is multiple choices for where you might transport, but potential surgical needs of the patient, cost of the patient, hospital resources. Some people said such and such hospital had poor PM staff, perception of poor care for patients with certain types of clinical conditions, and trying to avoid subsequent interhospital transfers. These were all part of that field-based decision-making process on where this patient should go. And lastly, the culture of triage, okay? This has been developed and enhanced over the last 30 plus years that when in doubt, take the patient to a trauma center. This is reflected by what we heard. It's a culture that encourages over triage, tending to err on the side of caution, There's little or no penalty for field providers activating the system, but under triage, that is missed patients, patients with serious injuries that wind up non-trauma facilities, strongly discouraged on multiple levels. With that, I'm going to transfer the mic over to Doug Boyce here, let him take the reins on the rest of this.
Thank you, Dr. Luther. So, as you guys can tell, I'm sorry, if you guys don't know me, my name is Doug Boyce. I'm the training officer for American Medical Response here in Clark and Calhoun counties. So I do a lot of the QA processes, and I'm very fortunate to be a part of the research age in my EMS career. I've been a paramedic for about 10 years, and things have changed a lot. And my personal opinion, I'm really excited about research that's been going on in Clark County specifically, because I've been dedicated to that through my position. And I want you guys to be excited about it too, because what this really does for us as providers is it gives us an opportunity to put input into the system you work, and you're trying to do no further harm, you're trying to make patients better. So what I want to say about this slide specifically is, as you know, gut feeling or paramedic discretion is usually on the bottom end of the 2006 CDC generated triage field guide. It's on the bottom. Why is it that we start from the bottom? Well, the heuristic approach for triage is experience, like Dr. Newgard was saying. And this does play a pretty big role in where we go. Fortunately, in this specific Tri-County area, we have level 1s and level 2 trauma centers within 8 minutes or less of most of our transports. For a matter of fact, Southwest is a level 2 trauma center. It can handle just about any basic level 1 as long as there's a surgeon on scene. So you'll see here that the big thing is the big arrow is the gut feeling. And closest appropriate hospitals. Thankfully, in this area, the closest appropriate could only be within 8 to 10 minutes. And also for like pediatric, it's discretionary of medical control to either go to a different hospital, burn patients, etc. This is kind of interesting. The specifics on this slide, the heuristic approach, the intuitive type of patient assessments we have, we do most of our patient assessments on the way. So we have a really, like Dr. Wilbur was saying, that our patient assessments and our dispatch actually plays a huge role in what we are thinking about, and we're actually making decisions before we get there. That's pretty important, and that's legitimate too. So in my small tenure as a provider, I've seen some pretty significant changes to EMS and how we approach patient care and patient assessment. So Dr. Newgard actually asked me, tell them what you think about what's going to happen with your triage. I don't think a whole lot's going to change in our trauma triage. I think we do leave it up to the paramedics to make those decisions. I'm very deeply vetted into the quality assurance program in Clark County. And as you saw on a slide earlier, it'll actually tell you that we won't come down on the paramedic or the EMTs for erring on the side of caution going to a trauma center. I don't think a whole lot's going to change, but what this does put into light is the STEMI stroke and other specific conditions will actually be triaged a little more accordingly to paramedic discretion. So that's exciting to me. Kind of gives a open forum, or the paramedic discretion, it actually gives you a lot more opportunity to practice medicine and make more decisions for your patients. I just wanted to read a couple things that I thought, if you're an EMT, this is from the code of conduct or code of ethics from the NAMT. And when I became a paramedic, I said these oaths, and I like to read these for you. It's important that you still have the enthusiasm to help with the research. So it says a fundamental responsibility of the EMT is to conserve life, to alleviate suffering, to promote health, and to do no harm. That's important. That's important that you guys, for you to realize that. Make sure that it's included in your patient outcome or patient treatment and assessment, and you're trying to do your best for your patients. This is from the EMT oath, also from the NAMT. It says, I shall also share my medical knowledge with those who may benefit from it and what I've learned. I will serve unselfishly and continuously in order to help make a better world for all mankind. So, having said that, it kind of puts the research into a different light, I think. Very compassionate about it. Make sure that when you're in the field, if I see a lot of paramedic students here, but and a lot of other field providers, but make sure that you realize that you can make the difference, and going to the right hospital really does come from the gut. And this may or may not change how we look at how the protocols are set, but it's literally in your hands. So, thank you.
All right, we got a couple of minutes for questions as we're swapping out for the next slideshow. Any questions? Yeah.
I know down south they're working on a new stroke protocol as far as a legislative issue as where you can go. Is there something like that going on up here as far as a legal issue with it?
That specific question, I'd probably have to defer to either Mark Muir or Lynn Whitwer. I can tell you that in general, most states have been pushed to try to develop regionalized STEMI care and stroke care. So it's in the works in most systems. There's some lots of other kind of political and other hurdles to get past on actually implementing these things. Mark or Lynn, do you guys want to comment on Washington?
I would love to if I didn't hear the question. I'm sorry.
Oh, sorry. So question was whether there is a efforts to implement regionalized stroke care and some triage based on stroke for certain hospitals in Washington as well.
Absolutely. That is something that's happening at the state level for both stroke care as well as cardiac care, STEMI specifically. Creating designation for different types of interventions for both, depending on the level, much like the trauma system as it exists now. So there is a push by the state specifically for stroke and STEMI care.
And one other thing that was mentioned was that some of these things like STEMI are much more straightforward to identify in the field or cardiac arrest. So if you look at identifying a cardiac arrest patient, at least to a trained field provider, is I think much more straightforward than trying to identify the seriously injured patient out of the broader, very, very heterogeneous population of injured patients. We go through the same issues in the hospital. So one question that was not asked but sort of sets the stage for this next talk is basically how accurate is your own cognitive processing. So that last talk is going to be news to trauma surgeons who have been working on these protocols for the last 30 years and revising and developing that triage algorithm. Turns out that it is up for revision this year, and actually I'll be part of the group that meets at the end of April to go through that triage algorithm and update those findings. So I think there is an opportunity to integrate some of this information. So this next talk is by no coincidence looking specifically at the value of EMS provider judgment, our attempt to try to answer that question of how accurate your cognitive processing really is. So I'm going to present this with Captain Hollingsworth here. And we're going to start with a slide. This is the 2006 National Trauma Triage Protocol. Most of you have probably seen this at least in some form. This version of the triage algorithm, at least in outline, has been used for the past about 20 years. And this, with some slight revisions, is the most recent algorithm. I'll point out just a couple highlights here. So it's a 4-step process seeking to identify seriously injured patients. Step 1 focuses on physiologic criteria, Step 2 on anatomic, Step 3 on mechanism of injury, and Step 4 on what's called special considerations. And what we heard Doug Boyce mention just a couple minutes ago is that EMS provider judgment is actually the very last criteria on this algorithm, sort of a laundry list of all kinds of things